Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Improving Access to HIV/AIDS Care in the Rural South, Alleviating Structural Barriers Using Telemedicine. I am Rainey Campbell with the Southern AIDS Coalition. Just to give you a little background on the Southern AIDS Coalition, SAC was formed in 2001 and is a membership organization comprised of a unique partnership of government representatives, community-based organizations, people living with HIV disease, and business entities. SAC was born from the burgeoning numbers of people in the southern United States with HIV infection rates much higher than the rest of the U.S. population, particularly for newly diagnosed cases. While the southern states represent approximately 37% of the U.S. population, they represent over half of new HIV infections in the U.S. Federal funds do not meet the needs of those living with HIV in the South and are not equally distributed across the country. The disparate impact of this epidemic on Southern citizens, especially within communities of color, must be addressed. The Southern AIDS Coalition works to provide Southerners with the opportunity to receive adequate HIV/AIDS prevention information, treatment, support services, and housing. A regional membership organization headquartered in Birmingham, Alabama, SAC has a national reputation for leading advocacy and effecting policy change that improves the quality of life for those living with HIV in the South. The Southern AIDS Coalition would like to thank our generous sponsor, Janssen Therapeutics, and our partner, AIDS United, through the Southern Reach Initiative. Without their support, this broadcast would not be possible. We encourage you to visit our website, southernaidscoalition.org, to download the slides from today's webcast, to join our listserv, and make use of the many resources found on our site, including the 2012 Southern States Manifesto. We have a very distinguished panel for you today. Our presenters today are Sandra Percival. Sandra is the Program Director for Telemedicine and Distance Learning Initiatives at Medical AIDS Outreach of Alabama. Sandra came to MAO after more than 9 years in the U.S. Air Force, where she served as Public Affairs Specialist and Knowledge Operations Manager. Her background with the Air Force prepared her to step into a rapidly expanding program at MAO of modern technology to transcend the barriers of care for people living with HIV in rural areas. Dr. Prashant Batt will be next. Dr. Batt has been a physician with Medical AIDS Outreach of Alabama since 2010. He's been directly involved with the Alabama eHealth Initiative since the summer of 2012. Prior to that, Dr. Batt was a resident physician at Baptist Medical Center in Montgomery from 2007 to 2010. He received a master's in public health focusing on epidemiology and health disparities from the University of North Texas Health Science Center at Fort Worth in 2006 and was a physician with community and corporate healthcare centers in India between 2000 and 2003. Dr. Batt attended medical school at Manipal University in India. His interests include researching health disparities, looking for community-based solutions for global health initiatives, impact of chronic diseases on public health, expanding access to healthcare, HIV and its effects on medico-social fabric and chronic disease management. Mary Elizabeth Marr. Mary Elizabeth has been working in the AIDS arena since 1992, starting out as a health educator for the American Red Cross. While serving as health educator, Mary Elizabeth was awarded Educator of the Year by the AIDS Task Force of Alabama in 1998. Also during that time, she served on the board of directors for AIDS Action Coalition. Mary Elizabeth has served on numerous local, statewide, and national committees in a variety of capacities, including Chairman of the statewide AIDS Network for the American Red Cross, Chairman of the AIDS Service Organization Network of Alabama for the past 3 years, member of the Federal AIDS Policy Partnership, AIDS United's Public Policy Committee, and recently completed Johnson & Johnson's Healthcare Executive Program at UCLA. Since becoming the director of AIDS Action Coalition in 1999, Mary Elizabeth has grown the organization from a $500,000 yearly budget to $3.2 million annually, vastly expanded clinical care, established a CDC grant targeting African Americans, increased testing, recently added housing and substance abuse and mental health funding. Mary Elizabeth serves as a local, statewide, and national advocate for people living with HIV and AIDS in North Alabama. She has a degree in education from Nicholls State University in Thibodaux, Louisiana. So you may ask, what is telemedicine and why do we at the Southern AIDS Coalition feel it is important to share this information with you today? As most of you are probably familiar with, the release of the HIV Treatment Cascade in March 2011 revealed that nearly 3 out of 4 people living with HIV in the U.S. have failed to successfully navigate the HIV continuum of care. HIV service providers and stakeholders must examine the critical questions of why those tested and diagnosed with HIV many times are not linked and retained in care, and what barriers can be eliminated to make sure that HIV-positive individuals are getting the life-saving treatment that they need. The Access to Care Initiative Telemedicine sets to address this issue in the rural South. In the South, 2/3 of people living with HIV reside in rural areas. Research shows that rural persons living with HIV disease, as compared to their urban counterparts, suffer significantly higher problem severity ratings for several barriers, including the need to travel long distances to medical facilities and personnel, a shortage of adequately trained medical and mental health professionals, a lack of personal or public transportation, and community stigma toward people living with HIV. The Telemedicine Project in Alabama is able to provide a solution for all of these barriers. This project is one of a small cohort of sites around the country. It actualizes the potential of technology to dissolve the structural barriers to care presented by poverty, stigma, and simple scarcity of resources. It uses telemedicine for the provision of high-quality HIV/AIDS care, effectively dissolving the barriers to optimal engagement faced by rural consumers throughout the Deep South. Since it is not always feasible for service providers to travel to learn about a new program, SAC's goal is to bring the information to you. Today, we will meet the following objectives: discuss the benefits of telemedicine and how it can improve HIV treatment and care, provide concrete, realistic information necessary to implement a telemedicine program, and share information and coordinate stakeholders to improve HIV treatment, care, and prevention in the South. Here's what's ahead for today's program. Sandra will give an overview of the telemedicine process and why it works, including logistics and measurable outcomes. Dr. Batt will share the doctor-patient experience and how a medical encounter is conducted via telemedicine. And then Mary Elizabeth will provide perspective on how it has allowed her organization to expand its linkage, retention, and overall access to care. We will have time at the end of the presentation for questions and answers. The 800 number to call and email address to send in questions are on the screen now and will appear again later in the program. Sandra, let's start with you. Tell us a little bit about MAO and the Telemedicine Initiative.
Sure. Let's start with MAO's mission statement. We are a private, nonprofit, community-based AIDS service organization that was established in 1987. We've actually transitioned from a fully volunteer education and service organization to a full-time primary care facility. Our clients can access both medical and social services in Montgomery and Dothan locations and each of the rural clinics that MAO operates. MAO also provides HIV education and testing, mental health counseling to patients and their family members. We also provide community prevention education, quality services, and compassionate care to all of those infected with and or affected by HIV and AIDS. Our services include social services, medical treatment, medication assistance, pharmacist consultations, mental health counseling, patient education, prevention education, of course, HIV testing, And we also have food bank services, which have been a huge help in getting people and getting those patients to come to their appointments. What we try to do is we incorporate a whole life approach to treating HIV. What we found is if we can help these patients with the barriers to care, then they're more likely to be retained in care. And providing food bank services, social services, and translation and things like that has been a huge help in continuing to keep people in care. Just to give you some broad information of what telemedicine is, it's basically a video chat with a doctor. So if you've ever used Skype or any kind of video teleconference equipment, that is exactly what this is. What we do is we put a patient in a clinic site with a nurse or a practitioner, and they're able to then communicate with the specialist through the video screen. We use a high-definition camera and video screen as well as Bluetooth medical equipment. The Bluetooth medical equipment is really cutting edge. What we have is a stethoscope that our nurse practitioner can use in the room with the patient. And everything that nurse practitioner sees and hears, the doctor in the other room, be it across the state or across the country, can see and hear the exact same thing through their stethoscope and on the screen in front of them. It's actually 100% secure, so it's HIPAA compliant. Like we said earlier, I come from the Air Force, and the DoD's standard for encryption is 64-bit, but we use 128-bit, so we've doubled that. So it's 100% secure. And what this does is it transcends a lot of the barriers to care that people living with HIV and AIDS face, especially in Alabama and some of our rural areas. Those barriers are the increasing number of HIV diagnoses. We are dealing with an epidemic. We have a lot of patients, more and more diagnosed every year, and I'll get to that in a second. Our poverty rates in Alabama, which leads to a lack of transportation, health professional shortage areas, and stigma. And to give you guys a big picture of the stigma, even those of us who work in the HIV/AIDS clinics, we see a lot of stigma, so I can't imagine what our patients see. I'm relatively new to MAO, and when I told someone where I was working, they said, "Wow, I'm going to go sit outside across the street and watch who goes in there so I can laugh at them because they have AIDS." So we have to learn how to counter that so that these individuals don't have to feel embarrassed to go into a clinic to get care, because that's one of the biggest barriers that these people face. At the end of 2012, we had almost 12,000 individuals known to be living with HIV in the state of Alabama. Of those, only 41% had progressed to AIDS. I say only because what we're seeing is a flop in the proportions of HIV to AIDS diagnosis. We're seeing less and less progress to AIDS because they are linked into care and retained in care. The CDC estimates that about 18% of individuals who do have HIV are unaware of their status, which would mean that in the state of Alabama, we probably have 2,000 to 4,000 additional undiagnosed cases of HIV. And this is just a map that I pulled down from the ADPH report for 2012. You can see the darker areas are the higher concentrations of HIV diagnosis. Poverty rates. In Alabama, out of our 67 counties, 46 of those have poverty rates higher than the national average. 23 counties have poverty rates that are above 20%, and 5 have poverty rates above 30%. Wilcox County has the highest poverty rate, with 39% of the population living below the poverty line. And according to the U.S. Census Bureau, the average household income in Alabama is less than 200% of the federal poverty definition. What that means is that most of our patients in those rural areas do not have their own personal means of transportation. If they don't own a car, in the state of Alabama, we have a severe shortage of mass transit. So if those individuals can't get a friend to drive them to their appointment, then they're not they're unable to go. And asking someone to drive you to an HIV/AIDS clinic is a very, very hard thing to do, and a lot of people don't want to do that because they don't want to disclose their status. 17% of Alabama's residents live below the national poverty line. So here's a big picture just to give you a graphic of a representation of where that poverty is. And these are the areas where we're seeing an increased diagnosis. If we were to put those two maps side by side, the higher rates of diagnosis are in these poverty areas. With that, we also have health professional shortage areas. 62 counties are health professional shortage areas in Alabama. There are only 57 infectious disease doctors and 3 American Academy of HIV Medicine credentialed physicians, which would give you about 1 expert per 80,000 Alabamians, or 1 per 250 diagnosed cases of HIV and AIDS. If all of those doctors were actually practicing full-time HIV medicine, their patient load would be about 250, but we don't have all of those doctors practicing full-time HIV medicine, so their patient load is a lot higher, and we're seeing more and more doctors who are possibly overworked, and the patients are underserviced, quite frankly. And a map of the health professional shortage areas. You see the blue areas, the darker blue. The entire counties are health professional shortage areas. And the light blue are partial health professional shortage areas. So we've got almost the entire state in this predicament. With telemedicine, Alabama eHealth has placed clinics in Selma, Sipsey, and Florence, with corresponding hubs in Montgomery, Tuscaloosa, and Huntsville. What we've done is we've covered a broad area of geographic locations so that these individuals who are in those poverty areas who don't have access to a specialist can now go to those telemedicine clinics and get care right there in their neighborhood, whereas before the doctors would have had to travel, or those patients would have had to ask someone to drive them an hour or further away from their home. And we've seen a retention rate of 92%. That's 92% of all individuals that we've enrolled in the telemedicine program with MAO are still retained in care. We also have plans to expand to Troy, Clayton, and the Wiregrass area with a hub in Dothan. Dothan's already up and running, but we're in the process of making that into a hub area for those smaller satellite clinics that we plan to open. So it's just a map of all of our telemedicine locations and how far we've been able to reach. Eventually, what we want to do long-term is create a statewide telemedicine network where individuals in any county in Alabama can go into possibly their county health department location. And if we could do that, if we could get a telemedicine suite in every county health department location, that would put care right there in everyone's neighborhood so that they don't have to travel. And not only that, they won't have to deal with the stigma. The stigma is a big issue because right now we're sending people to HIV/AIDS clinics that are specifically designated for HIV care. And if we could send them to something that's not labeled specifically for HIV care, then those individuals could go into a clinic without automatically disclosing their status just for walking into the building.
Thank you, Sandra, for giving us an overview of the telemedicine and project in Alabama and the HIV/AIDS epidemic in Alabama. And Dr. Batt, you worked with Sandra at MAO. Could you share with us some of your experiences as a physician?
Absolutely, Rainey. Well, my name is Prashant Batt. I'm a physician with Montgomery Medical AIDS Outreach now. First of all, I would like to thank the Alabama Department of Public Health as well as the Southern AIDS Coalition for giving us this opportunity. And Rainey and Dane, thank you very much. And welcome to Montgomery, Mimar.
Thank you.
Yes. We will discuss a few thoughts about how a telemedicine encounter is conducted and how it is different from an in-face or in-person encounter, face-to-face encounter. And we will compare and contrast. And we will also discuss a few things about some of the success stories that we've had, some of the challenges we've had, and how anyone with an interest and resources can implement and replicate our success in telemedicine. The idea of telemedicine started in 2009 in Montgomery AIDS Outreach, what was then Montgomery AIDS Outreach, which is now Medical AIDS Outreach of Alabama. Thanks to our CEO, Mike Murphy, and Mimar. It started as a random thought after observing telepsychiatry, right, Mimar?
Yes, yes.
Once the telepsychiatry model, which was all pervasive and which was successfully being implemented, we thought how it could be utilized in executing and delivering medical care to our patient population.
Our original thought, Michael's and my original thought was through the AIDS United grant, it was an access to care grant,
Correct.
And we wanted to see if we could somehow increase access throughout all of Alabama. So this seemed like a natural fit.
Yes. Absolutely, absolutely. The Telemedicine Network, which was just a thought in 2009, came into fruition in 2011. The planning phase took a little longer, but the executing phase, which we implemented in early 2012. So the past 18 or so months, we have this telemedicine clinic going on. We are covering 2/3 of Alabama with our telemedicine network. We have 3 permanent sites in Montgomery, Huntsville, and Tuscaloosa, and we started off with 3 satellite sites. So the initial idea was to have a hub and spoke model. So the hub is a specialist, and the spoke is where the rural clinic is. Now it has evolved into a situation wherein the spokes are talking to each other because we have the talent and resources available in the spoke sites as well. Well, let's talk about what happens in a patient visit. I hope everybody has had at least a few patient visits, especially as children. So a patient visit comprises of a distinct set of events. The patient comes in, the nurse asks the patient if there is any specific complaint or a situation that needs to be addressed on that particular day, in addition to the routine follow-up or the visit. And the nurse also asks if there had been any medical events that happened since the last visit. And she or he proceeds to reconcile all the medications that the patient will be taking or is taking on that particular day or in the recent past. And then the patient's vitals are checked, and then the medical doctor or the provider or the nurse practitioner or physician assistant will be notified of the patient in the room. And then the provider walks into the room, talks to the patient, and then the interaction with the patient of a provider is also a set of events. So there will be an interview with the patient, and then there will be a discussion of the tests, and we will review the vitals, and we will review the, like I said, the labs and tests and such kind of things. And then there is examination, and then there is discussion of what we found, and a kind of grouping together of the data available. And then we come up with a plan which is agreeable to the patient. We also make sure that the patient verbalizes understanding. So in this one, as you heard Sandy say about telemedicine being a video chat, it is real time and it's high definition. So the nurse is present with the patient. So everything that the nurse does with the patient, being be it reviewing the chief complaint, what we call in medical terminology, or reconciling the medications, or checking the vitals, or checking with the patient about what happened in the interim, these happen. In the physician part of the encounter, interview with the patient is through the high-definition audio-video equipment. Examination comprises of inspection, auscultation, and palpation. For whatever it means that we have kind of sort of forgotten about percussion. We don't use that percussion very much because of the advent of the resources that we have. So interview the patient, the inspection part, sorry about that, inspection part is seen through the high definition video. Auscultation is done by the Bluetooth stethoscope, which is really cool in that my nurse actually puts the stethoscope, the chest piece on the patient, and I can actually, sitting 100 miles away, can listen to, this is our receptionist in Dothan, if you see the picture, and that's me sitting there, and I will access the charts through the EMR. So I will review the test results and such things with the patient in real time through the high-def video. And I will also see what is going on, what the patient is seeing from that end through that small little thing at 2 o'clock position in the high-def TV there. So we also have a Bluetooth ENT scope wherein we can check the ear, nose, and throat of the patient, and a dermoscope wherein we actually can take the pictures of the skin lesions or moles or whatnot, and we can actually tag it to the EMR. And we will discuss the results with the patient. And we will come up with a plan about do we continue the medications, do we talk about the diet and exercise and a complete plan to keep the patient healthy. And if there is any need for prescriptions, we will e-scribe it through the computer to the pharmacy of patient's choice. So this is what an encounter looks like. So the only handicap is the touch. Everything else is actually included in a patient encounter. The patient being in the room, the pressure, the temperature, the humidity of the patient's skin, that's the only thing that is not covered. So the limitations of telemedicine would be that, yes, of course, we are not able to do a pap smear. We are not able to deliver babies through telemedicine, yes. But for routine visits, especially in HIV and AIDS, telemedicine works as good as an in-person visit. Emma, do you have any?
Well, it's almost, in many cases, it really enhances the appointment because of the fact that the client, again, doesn't have to leave their community, and which I'm going to talk about in a little while. Some of our clients either have to travel an hour and a half, 2 hours, maybe just for a laboratory appointment where they're just finding out their lab values. Now they can do that through telemedicine, and it's much quicker and much less painful from the standpoint of having to travel such a long distance.
Yes, absolutely, Mimar, absolutely. We talked about the provider and patient interaction on telemedicine. Why don't we sweeten the deal? We not only take care of patients' health conditions, we also have a clinical pharmacist on staff who teaches and educates and counsels patients on, be it diabetes education, be it tobacco cessation, be it HIV medication adherence, be it diet needed to control their cholesterol, be it the diet or exercise needed to control their high blood pressure. So, and things that we could do on a day-to-day basis with respect to nutrition. We also have a clinical mental health counselor based in Dothan. You remember me telling you that the hubs have, the spokes have started to speak to each other. Dothan is and was a spoke site of Montgomery. Well, our Dothan site has a mental health counselor. We don't have one in be it Montgomery, be it Selma, be it Clayton or Troy. So we utilized that expertise